Good morning, everyone, and welcome to the first lecture of this course, The Art of History Taking. During this talk, we will be introducing to the subject and show you how is the marking system, especially for those who are going to sit for the basis exam of the MRCP. We will be talking about the basic elements of history taking, and we will be talking about how to prepare for effective history taking, questions to be asked to the surrogate or to the patient, and how to get the full mark and look professional. I must first disclose about the conflict of interest. The author do not have any conflicts of interest to declare, whether financial or non-financial. There were no conflict of interest that may have influenced the conduct or the presentation of this lecture, including but not limited to close relationships with those who might be helped or hurt by the publication, academic interest and rivalries, and any personal, religious, or political convictions relevant to the topic at hand. In PACES, different and combination of skills are assessed at each encounter. So in the history, there is 5 skills that will be assessed. First is the communication skill, the differential diagnosis. You have to set a differential diagnosis, a reasonable one, and the true diagnosis or the diagnosis the examiner want to hear from you should be present in this differential diagnosis. You should have a clear clinical judgment, and I mean by clinical judgment that you know what investigations will be done for the patient, what referrals will be done for the patient. You will be admitting the patient or you will be discharging the patient. This is all called the clinical judgment. And then concerns of the patient should be answered clearly. You should listen to the concerns of the patient. You should discuss it with the patient, and then you have to answer it clearly. And also the skill that is present all over the exam is maintaining the patient welfare. First of all, you have to take a consent to start the consultation. Tell him that your GP has written to me explaining that you have some trouble with your, for example, your stomach, trouble with your heart, or so on. So I would like to ask you some questions so I can decide the plan of management. Sometimes you need to write few notes and the patient will stop once you start writing. So tell him that I need to write few notes in my paper, so I am writing them down, and when I'm writing them down, I still will be listening to you. So he will not stop talking while you are writing your notes. Outside the room, you will be having 5 minutes waiting to go in, and also they will give you a paper. In this paper, you have to make a scheme for the history taking station. In this paper, you can start writing that I will do an introduction, okay, and also write my rule is, and my patient name or my surrogate name is, so on. All this just as not to forget what you will be talking about and what you will be discussing, and not to miss any point. Also remember that I will greet the patient or the surrogate, and we have to agree for the agenda. Also write the CO, means that I will ask about the complaint, and also write the differential diagnosis on the right side of the paper, so that you will never miss to make a differential diagnosis while you proceed in your meeting. There will be a history of present illness. In the history of present illness, you can also make analysis of the complaint and analysis of the system disordered. You can ask about the cause or risk factors, and you can ask about red flag, and we will talk later on about the red flag. And I mean here by red flag is the symptoms and signs that can make you raise the concern about serious illness, and then have a pause after the history of present illness. And also in this pause, you have to tell something. We will discuss this later on, and then start the system related review. It's not every system, but it is a systems related. For example, if you have a case of joint pain, for example, after analysis of the complaint of the patient, and after analysis of the system disorder, which is the locomotor system, and so on. You start by the system related. The system related here will be, for example, start by the skin, and then go to the GIT and the chest and heart and so on. So start by the most related system to this complaint or this disorder. And remember always to ask about the general questions, and we will discuss this later on. So what are the systems you are going to ask about? You will be asking about the cardiovascular system, the GIT system, the CNS, the genitourinary, the chest, and also don't forget the hematology, endocrinology, locomotor, and dermatology systems. And I put you one monomer called health, so that you will never forget to ask about them, because sometimes the case or the solution or the differential diagnosis or the true diagnosis is present in those systems. Let's take some tips. As I told you, after history of present illness, there will be a pause, and in this pause, you have to tell the surrogate, I have to ask you some more questions so that I can establish the exact cause of your current health problem, and will help me to offer you the most appropriate treatment. Because after the history of present illness, you are going to ask about every and each system, and this is quite boring, and he will be answering also yes or no, and this is very boring to the patient. Maybe he will lose his concentration. So now you are encouraging him, you are preparing him to take your questions and to think about them and answer them properly. Other parts of the history, I give them a monomer called BDFS2, and if you put this monomer in the paper, you will never miss asking about them, or even in your mind. They are the past history, the drug history, the family history, the social history, the sexual history, and never also forget to write that you will be asking about the concern and the impact on this on health of this patient, the impact of this disease on the health of the patient. Remember also, there are two types of history that you can ask about them, but not in every patient: the menstrual history and pregnancy, and the travel history. The concern may be asked several times. It can be asked at the start of the meeting, at the start of the discussion, and can be also asked by the end of the discussion, because as I told you before, the concern is a dynamic process that that's changing from time to time, and maybe while you are asking the patient and discussing his condition, he will have a new concern. So also you have to ask about the impact of this disease on daily activities. For the past medical history, there is also a special monomer that you can also memorize so that you will not miss anything. PATMIC. P stands for procedures, A stands for admissions, T stands for transfusion, transfusion of blood, plasma, and so on. M stands for morbidities like bronchial asthma, hypertension, diabetes. I stands for infection or immunization, and C stands for contact with sick patients or contact with animals. In females, you have to ask about the menstrual history, and this is by far very important, because you may request to give a drug for a female and she is already pregnant, which may harm her baby and so on. So you have to ask about the periods and the pregnancy and abortions and oral contraceptive pills. The social history, we have to ask about the recreational drugs, the marital status, smoking, alcohol, housing, psychological history, if there is any anxiety or depression, coping with his disease at home or her disease, occupation, the pre-morbid condition, and the function. This will help you to put a plan for this patient later on. I suggested here a time frame for history taking for those who are going to sit for the PCS exam. In this time frame, you can give a time for each part of the history, so that you will not miss anything, or you will not give part of the history long time and the other part very short time or can be even missed at all. You can start your general screening by asking about the general history, and in the general history I put a monomer for you which is S2F2WA. The S stands for swelling and sleep, and the F stands for fever and fatigue. The W stands for the weight, and A stands for the appetite. You can ask about the weight, ask him about any recent change in the weight, how many kilos, over how many days. Ask about the appetite, any change in your appetite. Ask about the fever, any change in the body temperature. Fatigue, any undue fatigue. Swelling, any lumps or bumps in your body. Sleep, any change in the sleeping hours. And if you ask about the weight change, immediately go and ask about the appetite. And if you ask about the oral ulcers, immediately go and ask about the genital ulcers. To screen for the gastroenterology, you have to ask the following questions. And remember also, we are asking them in order from the top to the bottom. So first ask about the mouth and end by the anal canal. Do you have any mouth sores? Is it painful? Any problem with your teeth? Is there any difficulty of swallowing? Sensation of food sticking in your throat? Where does it seem to stick? And it worse by fluid, or is it worse by fluid or solid? You have to ask about the pain also during swallowing. Then you go down slightly, ask about feeling sick or being sick, retching or regurgitation of clear tasteless fluid, are you getting sick, and so on. And feeling sick means that nausea, and getting sick means vomiting. This is the lay people language. You have to use this, and you have to use a jargon-free language so that the patient can understand what exactly you mean by what you say. And you ask him about the color, how many times, is it related to pain or not related to food, what relieves it and what exacerbates it, does it contain any trace of blood, we mean here by the vomiting, any indigestion, can you describe it to me, and any heartburn, and also you can ask him, can you describe it to me. We'll continue with the gastroenterology symptoms. Do you have any tummy pain, and also do the analysis of pain if any. Did you have any wind? Does it pass downward or upward, and we mean here by gases or distension. Ask about normal bowel habits. How many times is normal for you, and now how many times, what color is it, and is there any blood, slime, and what about the odor. Slime means mucus. Associated with abdominal pain, is it difficult to flush away or not? Does it smell or float? Is there incontinence of stool? When you try to open your bowels in the morning, does it seem to be your usual habits? Do you have sensation of needing to go without evacuation, and so on? Did you have any discoloration of your eyeball or skin? And by the end of asking about the gastroenterology symptoms, you can ask about pain, and in the side back means pain around the anus. For the genitourinary system, you have to ask about any problems with your water work, any pain during or immediately after passing urine, repeated desire to micturate, and remember here frequency means passing urine with repeated time without change in volume, and urgency means sudden need to pass urine. Ask about stress incontinence and urge incontinence, hesitancy, and polyuria. For the cardiovascular system, you have to ask about the chest pain, shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, and so on. Ankle swelling, awareness of heartbeats, blackout, and leg pain. For the chest, you have to ask about the cough, phlegm means sputum, hemoptysis, shortness of breath, coughing of blood, noisy chest, chest pain, sleep affection, snore during sleep in case of obstructive sleep apnea, change in the voice character. For the neurology, you have to ask about the headache, eye affection, photophobia, neck pain, confusion, fever, drowsiness, double vision, and so on. Fainting and blackouts, funny turns or fits, weakness or numbness, tingling sensation, pain and pins and needles in the limb, a special sense, smell, hearing, taste, eye, and swallowing, unsteadiness in the dark and during walk for the dorsal column, and the gait, water, work, and back passage, affection, and controlling, like in transverse myelitis and conus medullaris diseases. Did you have any change in your mood or concentration, memory, or behavior? So also a psychological element must be asked about. For the hematology, you can ask about any bleeding spot under the skin from the teeth, gums, or from the nose, any recurrent infection, and so on. For the locomotor system or the rheumatology, ask about the joint pain, stiffness, swelling, and deformity, muscle aches and weakness, Raynaud's phenomena, eye changes and bowel changes, and pain, stiffness, swelling, and deformity. For the skin, you have to ask about the skin rash, color, size, shape, itching, discharge, hair loss, or abnormal growth of hair. For the sexual history, there are some tips because sexual history is a very private history as well as the menstrual history. So before starting asking the patient, you will request from him to accept that you ask him. You can say, I want to ask you some rather personal questions, if that's okay for you, and then start asking about the sexual history or the menstrual history. We usually ask them to our patients. That's what you will be saying to him, because sometimes the patient will say, what do you mean by personal questions? So they are normal questions. We usually ask them to our patients so that you will just put him at ease. Then start asking him, have you a regular sexual partner? Is it male or female? Are you practicing safe sex? Are you worried about what you might have picked anything from sexual intercourse, and so on? Do you have any change in your sexual desire or ability? Ask about scrotal pain or swelling. Ask about anal discharge, rectal bleeding. Ask about ulcer at penis, rash or wart. Ask about vaginal discharge, and so on. For females also, ask about the menses, pruritus, vulvae and sores, dyspareunia, and post-coital bleeding. So the wrap up will be, by the end of this discussion, you can ask him about the secondary concern, and if you have time, ask him or her to summarize and check understanding. But usually in the history taking, there is no much time to do so. So explain for him the plan, the investigations, the treatment, the possible response time, and the possible side effects, and also tell him about his disposal, means next follow-up, if you are going to admit him or if you are going to refer him to another subspecialty, and so on. All this are very, very extremely important, and also the examiner like to hear it from you. Also offer some help like websites, leaflets, and hospital contact number, but never tell him that I will give you my number or my personal number. Remember, for the secondary concern, to ask him this question. Tell him that, do you have still any concern or questions that was not discussed and you are worried about and you want me to discuss it with you, and so on. This is very important, and also the examiner want to hear this from you. By the end of the talk, tell him that we have discussed everything, and your symptoms possibly due to, and tell him the disease. Mention the diagnosis in medical terms, and tell him, don't bother yourself with difficult names, but this means that, and try to explain the diagnosis. So first tell him the diagnosis, for example, rheumatoid arthritis, but tell him that don't bother yourself with difficult names, and I will tell you what does that mean, and start explaining the diagnosis. And also the examiner would love to hear this from you. And then, as I told you, start by giving him the management plan, which is the clinical judgment, and you will be marked for. After you finish the meeting with the surrogate or the patient, the examiner will be waiting for you, and his first question will be, what is your differential diagnosis? And as I told you, you have to prepare the differential diagnosis by writing the most common differential diagnosis and the most common things that you are thinking about on the right side of the paper. And the second question will be what you will be doing for this patient. So you'll start by, I will request basic investigations, investigations to confirm the diagnosis, investigations to search for the etiology and complication, and I will put a management plan for this patient and start discussing the management plan. This will come in the next slide. We will give him a symptoms control, and we will try to manage the underlying disease process. So the treatment plan would be usually non-pharmacological and pharmacological, and this is applied to all cases. It depends on individual or each case, but this should be mentioned in every case. The non-pharmacological should be psychological, social, occupational, and educational support, physiotherapy, and avoidance of triggers, and this is individualized according to each case. I mean that not on every case we have to tell him that we will make all these types of referrals, or we will do all these types of non-pharmacological management, but it depends on each case. The pharmacological, also you can mention also the medications that you will give to the patient, and finally the vaccination and possible isolation. By the end of this talk, now we are able to recognize the basic skills needed for history taking and recognize the basic elements of history taking. Now we know how to prepare for effective history taking, and now we know also how to explore the agenda of the meeting and have the correct differential diagnosis. We also now know how to ask about the different systems. Thank you for listening and wish you all the best.